Okay, so the GI oncologist in the future. Actually, I want to start with back to the future. What are the advances we anticipate over time? And you know, the flux generator took us, actually was able to move the actors forward 30 years to 2015, and actually October 21st, 2015, as you all know, is Back to the Future Day. And at that time, of course, we had flying cars. That was what we thought in 1985, that 30 years later, the main improvements that we had in life was flying cars, hoverboards, etc. And you know, this didn't happen. What happened was actually this. The transformation into the information technology era. It's data and communication. Data and communication. And actually, for those of you who followed the news, the iPhone was released 10 years ago, 2 days ago. And I remember actually being here in Barcelona ordering my first iPhone the moment it came out. I'm one of those early adopters. This has really changed the way we see the world, communicate. Data and communication. So on a colorectal cancer perspective, what happened 10 years ago, we had oral session at ASCO, Cairo 1 was presented, Optimox 2, updates, Mosaic and N9741, non-colorectal cancer session was GEM plus minus bevacizumab and cetuximab, called C225 at that time. And there was some S1 testing in gastric cancer, etc. There was no data at all on mutational testing. It was before we actually really embraced KRAS, nothing about MSI, very few presentation biologics, no biomarker-defined subgroups, and all trials really had one-size-fits-all designs. A lot has changed. That's just 10 years. That's just 10 years. So I want to give you 4 points that I think are important for the GI oncologists of the future. First of all, very importantly, communication with our patients will change. We'll come through wearable devices allowing for real-time communication and side effect assessment. We can monitor side effects in real time, and these devices, like whatever you call it, whether it's an Apple Watch or Garmin or whatever Fitbit enhanced device, will be able to communicate with us, with the providers, and provide us very important data. We'll have virtual visits with the patient, more or less. And I think that's important. We already saw data at ASCO this year, a second presentation, the plenary session, how important it is to really allow patients to communicate with providers in real time. Very elegant presentation by Ethan Bash, looking at the standard approach for symptom monitoring, which is really like when patients come back over time, we actually see them every 3 to 4 weeks, and then they report about their side effects, and they're really reluctant. There's reluctance to communicate with us outside of these, when these side effects, outside of our regular visits. So we address side effects reactively. But the study group at Memorial Sloan Kettering actually looked at a proactive way, allowing patients to communicate in real time through a web-based approach. And now we can talk about in the future, wearable devices might do that in real time by monitoring patients' heart rate, rhythm, oxygen, glucose concentration. All this is possible, and we can then initiate a proactive approach. In this study, 766 patients at Memorial with various malignancies were randomized to the standard way we assess symptoms and reactively address them, or prospectively really prompting patients. A patient gave us symptoms continuously, but they still had to do it themselves. Again, wearable devices will do this automatically, and then nurses and physicians could react to that. So one of the patient-reported interfaces evaluated shortness of breath, very easy. 1, 2, 3, a grade 1, 2, 3, 4, according to CTC criteria, patients could grade their side effects. And this is automatically transmitted to the providers, and they could then, upon a certain threshold was reached, call the patient back and then initiate some symptom management. And the important point was here, this improved survival. This improved survival, a median survival of 5 months in all tumor types. So we already have proof that this proactive management of symptoms can be life-extending at least. It also reduced the numbers of ER visits, was more cost-efficient, etc. This will come over time. This will be enhanced by technology, by the ways patients will communicate with us. Second point is we need to understand molecular pathways in a different way, and we'll utilize them in different ways. So, right now when we try to be fancy here at this meeting, we look at the MAP kinase pathway and talk about what's the best way to inhibit BRAF mutations, and then, counterbalance some feedback activation. But this is not what biology looks like, and I like to show this is really what biology looks like. And this is a cell with pathways. No, it's the subway of Tokyo. And I've used this slide before because you can easily see if you just block one of these lines, you cannot shut down the whole system. You need to take out the interfaces, the nodules of intersection. So how do you know what these intersection pathways are, intersection nodules are, that are very important for tumor biology? Because right now what you do when you do your tissue-based analysis, cellular-based analysis, molecular-based analysis, and even if you put it all in one database, which I think is another step what we need to do in the future, you generate a lot of data, and you see these network interactions. A lot of different dots over time, but fortunately there are algorithms, and this goes way beyond what I understand, that can condense and interpret these network interactions and really bring this scattered 1,000-point network down to a couple of places, couple of intersections which really matter, which we then can inhibit with 1 or 2 or 3 drugs. But this might be different from patient to patient, from tumor to tumor, from first line to second line, and depend on treatment intervention. But this is something that's going to happen once we use AI, artificial intelligence, and apply it on the big data that we're generating right now with molecular analysis, gene expression pathways, and on a cellular and a tissue level. We will use circulating tumor DNA much more broadly. And you've seen talk after talk after talk here talking about circulating tumor DNA or other circulating markers, methylation markers, circulating exosomes, etc. And just to give you a list of 5 areas where I think we're going to be seeing advances, the last one, probably the least advanced one in 10 years, will really see studies on marker using circulating tumor DNA as marker of minimal residual disease to tailor adjuvant therapy. We'll use it as a monitoring tool in surveillance. Do we really need a CT scan when no circulating tumor DNA is present? These are studies that can actually be cost efficient and lower the dose of radiation, for instance, in healthy and cured patients. Great potential here. We'll capture the integral of all the molecular alterations in a heterogeneous tumor with various metastases, can address the molecular heterogeneity, select targeted therapies and combinations, and then fourth point, monitor treatment responses over time because blood draws are easy to do. And the holy grail would be cancer screening total population. Again, this is something further away. The fourth part is immunotherapy will be standard treatment and first-line treatment for most patients, likely in combination with chemotherapy, other agents. This is where we are right now. IO has efficacy in 0 to 20% of patients, high response rate in MSI-high colon cancer, but low frequency of MSI-high in colon cancer. Then anything from gastroesophageal and anal cancer shows some responses. Pancreas cancer is the one desert right now of immunotherapy. Hopefully we'll see improvements there. And the idea is there are various approaches to make these tumors more inflamed, to really activate the immune system, make them immunogenic. And there are certain inducers of immunogenicity or enhancers of immunogenicity, chemotherapy, pathway inhibitors, combined IO approaches, and bispecific antibodies. Dr. Tabanero showed us a very interesting example of that, and other factors which we'll explore in the next 10 years. The door is open, and we'll walk through that. So what else can we expect? And this goes beyond medicine now. I actually believe we'll have bioimplants that interface with external technology. That's already happening. We can make deaf people hear again, blind people see again. This is already there. We'll have augmented reality devices. Wait till the iPhone 8 comes out, you know what I'm talking about. You put your phone up while you're walking through a city, and you look at it at a, let's say, statue, and we'll explain to you exactly what it is. And when you look at the next Starbucks, you'll see what a cup of coffee will cost, whether any specialty. Augmented reality will be reality very soon. iPhone 14 will come out in 10 years, and it will be so thin it can be rolled up. you know? Of course, that's what's the future. And we'll have self-driving cars. But even in 10 years, on Back to the Future days, I don't think we'll have flying cars. This was a wrong assumption that we made 30 plus years ago, that we will have flying cars. The emphasis is really on data, on communication, and this has heavily impacted medicine. Thank you.